So I'm Dr. Charan from Srinathra Hospital, Vijayanagaram. At the outset, I thank APOS and AOS for giving me an opportunity. So this is one slide which never we want to see on the first post-operative day. So it's a nightmare for any ophthalmologist looking at looking at a patient with this kind of scenario. The most and why this happens, majority of times we are not being properly trained in our post graduation or even in our fellowships about how to sterilize and what are all the instruments which are we should buy or which are being used in sterilization, and all of these things happen at a backstage, and we are never been trained at all in sterilization techniques in our practice or in our post graduation. So I want to briefly go through the sterilization techniques, how we do and how you maintain your ophthalmic OT, how you clean your ophthalmic instruments, and what are the type sterilizers we can use in ophthalmology, and how you can monitor the sterilization and by the types of indicators which we use in ophthalmology, and how you sterilize if you do an high risk case like an HIV or HBsAg or any other viral infection. So coming at least from the definition, we see that sterilization is a process which eliminates all forms of microbial life. All forms includes, it should also eliminate bacterial spores also. So coming to the first thing, how you should have an ophthalmic OT. Suppose you are planning to construct an hospital, you should see that your ophthalmic OT and your OPD services are not there in the same floor. Your ophthalmic OT should be away from your ophthalmic OPD services. This is required. Why? Because number of personnel in an ophthalmology OPD will decrease the air quality, and this might increase the infectious rate. So your ophthalmic OT should always be there. It should be away from your OPD services. Preferably, it should be there in the first floor. Again, when you are constructing an ophthalmic OT, it should have 4 zones. It should have an outer protective zone, which is the reception area, and a mid clean zone, which is for the changing rooms, and a third room, which is the crux of your ophthalmic OT, the operating room, which is otherwise called aseptic zone or a sterile zone. And finally, you should have a disposal zone for disposal of all your instruments after you complete your ophthalmic OT. So suppose you are starting your ophthalmic OT for the first time, or you have not operated for a long time, or if you have done in a civil work, do not start your OT until you do at least 3 OT washings, and you send the culture for at least 3 times. You should get 3 negative cultures before starting an OT. Suppose if it is a running OT, it means OT which is always which is in use. A single fumigation or disinfective mopping daily or fogging is enough. So fogging can be done both by formalin or by an aseptic solution like bacillocid. And you should always remember that once you have done fumigation, you should close the OT for at least 6 hours after fumigation. And if you have an UV lamp, it is preferable to have an UV lamp, and this UV lamp should be used at least 12 to 16 hours for your proper sterilization. But it's not mandatory to have an UV lamp in your OT. So, but remember that you can have an UV radiation hazard, so you should at least switch off the UV light 2 hours before entering the OT. So, if most of your OTs are all the OTs are with air conditioned, so it's always preferable to have a central AC and split AC if your economy doesn't permit. But window AC should never be used in an ophthalmic OT, because you cannot sterilize, or you cannot be absolute sure of your sterilization if you are using an window air conditioners. An AC filter should be cleaned every week. The floors, microscopes, surfaces should be cleaned with 2% bacillocid daily. The wall tiles, if you are using an wall tiles, you don't have a modular theater, which many of us, so this wall tile should be cleaned up to a height of 4 feet. These are the AOS guidelines to prevent intraocular infection. So once you complete your operation theater, there is one more thing called you have to see that you are cleaning all the OT instruments. Immediately after the OT, soak all these instruments in water and clean all the instruments with Savlon. Savlon, I think it's a mixture of chlorhexidine, citramide and isopropyl alcohol. And you should see that you clean all these instruments with a toothbrush, so that you are eliminating all forms of any dirt or anything which were used in the operation theatre. And finally, after Savlon, you have to again rinse with water, and finally you see finally after rinsing with water, dry all the instruments. If it is preferable to use a dryer and before wrapping all the instruments. And coming to the sterilizers, there are two types of sterilization techniques. One is in physical sterilization and another is in chemical sterilization. Physical sterilization is most commonly used in our practice, and chemical sterilization is which we use with ethylene oxide or hydrogen peroxide. So physical sterilization is the most common form of sterilization what we do. Steam sterilizer is the most common type of sterilizers in the physical sterilization, because steam is microbicidal, non-toxic, and also it is inexpensive. So how does a steam sterilizer work? A steam sterilizer works by transferring the heat energy onto the bacteria and killing them. So, and if you are and a pressurized steam is more effective than a normal steam. So one very important thing about steam sterilizers is air. If it is present in the sterilizer, it hampers your sterilization process. So you have to see, you have to take a sterilizer where there is an air removal mechanism from the sterilizer, so that this heat gets transferred onto the your wrapping or bin. So steam sterilizers, another important thing is these steam sterilizers do not work very well for hollow tubings, since air gets trapped in these hollow tubings. Suppose you take a phaco handpiece or phaco tubings, and air will not prevent these steam to enter into your hollow tubings. You should have an effective mechanism where you remove air from all these tubings. So with this knowledge, we have two types of steam sterilizers. Where you have an active vacuum pump which removes the air from the sterilizer, and then another type of sterilizer where you don't have an active vacuum pump. So the first two, the cooker sterilizer and vertical sterilizer, these are two types of sterilizers where you don't have an active vacuum pump. And the third one, the horizontal sterilizer, is with an active vacuum pump, but this horizontal sterilizer usually has only one vacuum pump. And the fourth one is a tabletop sterilizer, which is used for lighter instruments. And in this tabletop sterilizer, again you have three types of tabletop sterilizers. One is an N type of tabletop sterilizer, S type, and a B class autoclave. So and this is all these sterilizers are steam sterilizers, but N type doesn't have an active vacuum pump. There is no removal of air from the bin. And S type of tabletop sterilizer has one cycle of air removal, and a B class autoclave, which is the topmost autoclave, has 3 cycles of air removal. So B class autoclave is very highly if you are doing phaco on a regular basis, then it is better you sterilize your phaco tubings in a B class autoclave. So flash autoclave, if you are using a flash autoclave is not recommended. We do not guarantee the sterility of instruments in a flash autoclave, because it's done for about 7 minutes or 8 minutes. So flash autoclave, still if you want to use, you can use it on an emergency basis. Suppose something falls down from your from the table down and you have no other alternative, still then in cases of an emergency, you can use a flash autoclave. And once you have autoclaved the instruments, one more very important thing is how long is the shell life of the instruments which are autoclaved. Usually it is between 24 to 48 hours, and it is better to re-sterilize if the wrapping load is more than 48 hours. In our hospital, we usually do it within 24 hours. We use 24 hours. Beyond 24 hours, we re-sterilize the instruments. So now coming to the type of indicators. So you have to know, validate your sterilization process. There are two types of validating procedures. One is a chemical indicator and other is a biological indicator. So chemical indicators use sensitive chemicals, and they change color when exposed to higher temperatures. There are 6 types of chemical indicators, type 1 to type 6, and they monitor the parameters of sterilization like steam, pressure, temperature, and time. So this is the ISO classification of the types of indicators: process, specific use, multivariable, single variable, and all these things. What we normally should be using is a type 4 or type 5 indicators, which will test all the components of sterilization like steam, temperature, heat, and all. Then helix tube is a specific type of chemical indicator which is used to test your sterilization process of an hollow instruments like your phaco tubing. What happens in a helix tube is, if you see there is a knob here. This is the indicator. Indicator is placed inside the knob here, and once you do an sterilization, the steam goes through this tubing and finally reaches here, and this indicator will change the color. So once this indicator changes the color, you are sure that the sterilization is complete. So once the sterilization is complete, you are pretty sure. This is very, very useful in hollow tubings, especially your phaco tubings. So biological indicators usually contain viable microorganisms like Bacillus atrophius spores, and these Bacillus atrophius spores, when they are exposed to higher temperatures, they get killed, and these biological indicators, after sterilization, they can be sent for culture, and once your culture comes negative, then you are pretty sure that your sterilization is absolutely working fine. So what are the AIOS guidelines for monitoring of sterilization? AIOS says that you should use at least 3 chemical indicators, type 5 or type 6. One you should use outside the wrap, one you should use inside the wrap, one inside the tray. And if you are doing a large volume surgery, biological indicators should be used every 3 months. And the proper logbook maintenance and surprise checks of your sterilization process should be done. A chemical sterilization, there are 2 types of chemical sterilizers. One is an ethylene oxide sterilizer, one is a plasma sterilizer. Each one has its advantages and disadvantages. I'm not going through all these things. So each one works by one thing. So ETO sterilization uses ETO gas, and plasma sterilization usually uses hydrogen peroxide. Both of them are low temperature sterilizers. The one advantage with plasma sterilization is a fast sterilizer. Usually it takes about 75 minutes to complete a sterilization, whereas ETO has advantage that it works much better than a plasma sterilizer in a sterilization thing. But the important disadvantage with ETO sterilizer is it is a long duration sterilizer. Usually for an ETO sterilization process usually takes 6 to 10 hours time. So you have to keep it overnight for sterilization. And other disadvantages, ETO is hazardous and toxic and cancer forming gas. So you should always have a proper aeration thing in your hospital to see that ETO is properly being disposed. And finally, sterilization. If you are doing high-risk cases like HIV, HBsAg, and HCV, so what we have to do, routinely screen for all viral markers. It should be done as a last case in the OT. You should remove all unwanted instruments from the table. Use double gloves, shoe cover, and it is always better to use disposable linen rather than your regular linen. And it is better to see that there are less number of personnel handling the operating table while you are operating in a high risk case. It is better you yourself handle majority of the operation theater at that point of time. So once you complete an high risk case, what you have to do, you have to soak all the instruments in hypochlorite solution for 30 minutes, wash the instruments and linen. And what is more important is, once you have done an high risk case, at least you should do a 2 times autoclaving. So 1 time autoclaving is not enough. So you should do a two times of autoclaving. And before doing a routine sterilization thing, floors and tables should be cleaned with hypochlorite solutions. Wall cleaning with hypochlorite solution is not routinely necessary because you don't have spillage from the table onto the walls. So the take home message is proper sterilization is highly essential for a successful surgery. Dedicated and trained OT staff should be present. Meticulous documentation of sterilization process is highly recommended, and you should strike a right balance between the economy and efficiency of the sterilization equipment. And upgrading to latest and contemporary sterilization techniques is always mandatory to every practicing ophthalmic surgeon. Thank you.